This week on the Backtable podcast.
And I just want more doctors to understand that there's opportunity for them to take a more active role in shaping how the future of healthcare looks. I think that gets lost a lot because I think, you sit in the surgeon's lounge or the doctor's lounge and you listen to all the complaining or you read the headlines and you're like, oh my God, Amazon Health, One Medical, Dollar General Mobile Clinic, CVS Clinic. Like, I'm powerless in this system of giants and behemoths that are changing my field. If you back up and you recognize that there's opportunities to cut out some of this middleman, take ownership, think outside of the box. There's a lot of opportunity to kind of shape the future.
Hey, Ruchi.
Hey, Anish.
Or Dr. Talwar, I apologize.
Ruchi's fine. Ruchi's fine.
Ruchi, you told me one time that healthcare is broken, and I told you I didn't agree. So,
Good start. Already disagreeing.
So why is healthcare broken? Give me your top 3 points on why healthcare is broken.
Top 3. That's going to be the hardest part about this.
All right, give me your top 10.
3. No, I mean, the list goes on and on. Well, healthcare is broken for so many reasons. Can I just skip to the solution?
Yeah, sure.
Because healthcare is broken because of the way we pay for it. No, seriously, I think that's the problem. That's the fix. Why is healthcare broken? We spend more money than any other developed nation in this country on healthcare, yet we have the worst healthcare outcomes compared to our counterparts. That sums it up for me quite nicely. We have extremely high burnout rates in our healthcare workers, physicians, nurses, everyone in healthcare. In 2023, the U.S. spent $4.9 trillion on healthcare. $4.9 trillion. That's a 7.5% increase year over year. And what do we have to show for it? You tell me.
So, let me ask this. Is part of the problem that docs get paid too much or too little, or are they getting paid just right, or what does this have to do with anything?
Let me reframe it. I would say the problem is not how much doctors get paid. The problem is, one could argue, probably too often blamed on physician payments. Instead, I think the problem is misaligned incentives. It's a behavioral economics concept. You're not incentivizing people the right way, whether that's through money, whether that's through some other sort of incentive. And so you create a broken system.
Okay. So, part of, is being partially facetious, but I was like, it's not that broken in the sense that my parents were immigrants from India and they were doctors and they had a great life and provided for a great life for me and my brothers, both of whom are doctors, and my sister-in-law and 6 cousins. Not me, I'm not a doctor. But it seemed to work out well for them. And I'm not saying it's perfect. It's far from perfect. But every time I've had an issue, and a lot of other people I know, and this is just me and my little bubble world, anytime me and the people I know have problems, we seem to get taken care of. And I can get almost any kind of healthcare I want, pretty much. Now, the key thing is as long as I'm willing to pay for it, or somebody that I've contracted is willing to pay for it on my behalf. And maybe that's part of the key issue. Although I'm also free to go to India and buy whatever healthcare I want if I don't like what or whatever country. But anyway, that's why I'm like, come on, it's not that broken.
Yeah, but that's you, and you're lucky, and you have resources, and you can get to the hospital, and you have access to a car, and, we won't get into all that, but just calling that out,
What you're saying is it works well for some people, and probably the more resources you have, the better it works for you.
Yeah.
But it doesn't work well for everybody.
Correct.
Is what you're saying. And the less resources you have, the worse it works.
Absolutely.
You see that. Tell me, you firsthand, you've seen some of this, right? I've heard you talk about, you treat GU cancer, so a few different types, but just curious, how have you seen this show up for you?
Oh my gosh, so many ways. I think the fundamental thing that you alluded to earlier was that I made the statement, healthcare's broken. I talk about how often I think it's broken because of how convoluted the payment system is. But as you said, what does that mean in reality for our patients? process of going to obtain healthcare is far too complex. The majority of people who get insurance get it through an employer. It's employer-sponsored insurance. Even if I get my insurance or healthcare coverage through an employer, that doesn't mean that I'm free to go anywhere. I have a specific network of doctors I can see, some I can't see, some are covered at higher rates than others. I don't even know what's going to be on the bill that I get after I either go to see the doctor or go to the hospital. Even if I need a medication that's covered, and you asked me what I see in my day-to-day, let's talk about some of my cancer patients, prostate cancer patients. Those who have prostate cancer that's already spread often need medications, systemic medications they take either orally or through the IV. Even if they have insurance, they don't know if that medication is going to be covered. Now, let's even add another layer of complexity to it. Even if the medication is covered, they don't know how much they're going to owe because it's going to be covered at different amounts. Depending on how much they've already spent on their healthcare this year, they may have to pay for some of it. They may have to pay for all of it. They may have to pay for a percentage of it. And then those are people who have insurance. Some people don't even have access to insurance. What are those folks going to do? They can't even schedule an appointment to see certain doctors. Medicare, that's a whole different mess of a system because Medicare really dictates how doctors get paid. They set rates, essentially, for most services that you can get from a physician. But those rates end up being often so much lower than the cost of actually providing that care that then two patients can have the same surgery at the same hospital on the same day, even by the same surgeon, and the amount the hospital gets paid could be completely disparate between a Medicare patient and a commercial patient or a self-pay patient. Why is it so complicated? Why is it so complicated, Anish?
Well, I'm sure I can't tell you the answer of why it's so complicated. I would say a couple of things in response. I think I hear you on all that, and that's unfortunate for sure. I'm very much a glass half full type of guy, so I'm like, well, I think it's amazing that all of us even have a shot at getting these amazing medications. If we, end up with prostate cancer, bladder cancer, whatever it might be, the modern world is such that. And I think, and you can correct me if I'm wrong, it's in part driven by the healthcare system in America and the pharmaceutical industry in America that we even have access to medications like this. Not going to be true forever. I think, other countries, China in particular, are really catching up in some ways, which is great. But for the last, call it 50 years or maybe more, that system, as convoluted and imperfect as it is, has been responsible for unbelievable innovations that have given us a shot at being healthy. And I'll just throw a word in here, and we're just being philosophical for a moment, but it's more about if I get prostate cancer, am I entitled to have this treatment? I'm like, no, I'm just fortunate if I got a shot at it. But it is true that I am more fortunate than a lot of others. So I totally hear that point. What I've heard you talk about in particular, it is socioeconomically disparate, meaning a person's going to have to drive to see you.
Yes.
Because of the academics or cancer center or whatever that you're at, where they can't get this treatment somewhere else. And then they may not have access to that car. And then they may not be able to leave work because they're going to lose wages and all that stuff. And then they're like, well, I can't get this treatment because it's just not possible for me, which is imperfect and unfortunate. And anyway, my opinion, and again, this is just an opinion, is simply though, you ask, why is it so complicated? I don't know. Well, we can get to it. I don't know that that's the right question even. Like, why is it so complicated? It's because it's a man-made system that evolved with cooperation from the government and private, individuals, and it's supposed to cover sort of everybody. That's maybe why it's so complicated. But you talked about how people are paid. And so I kid a little bit only because I've been hearing since probably 1985 about how the healthcare system is changing and doctors aren't getting compensated the same and the system needs to be fixed. And I blame my dad for that. And I kind of learned to tune it out a long time. I was like, what are you talking about, Dad? You're fine. But I know that it's also more nuanced than that. So how do you explain to me, the layman, value-based care versus, let's just call it episodic care, and where do RVUs fit in? Like, does anybody understand these things? Like, what is this?
Yeah, it's confusing. It's confusing. Well, listen, healthcare has changed, as you alluded to, and I think a lot of that is because of how people pay for their healthcare. I'll just add that, insurance is really supposed to be risk mitigation. If you think about it, it's not supposed to pay for everything. It's supposed to cover you in a catastrophic event. The problem is everything's gotten so expensive that we can't even afford the basic care.
Wait, what do you mean? But I mean, I actually, so risk mitigation, I actually agree with you completely.
Yeah.
As an individual who has for a long time bought my own health insurance.
Yeah.
And then as a business owner who has bought health insurance for my company to provide for employees, including myself, when I look at the insurance rates, I'm like, well, this is a racket. I mean, I'm paying for this one way or the other. Like, the insurance company is not really paying for this unless it gets real bad.
Yes.
That's the only scenario where they're paying for it. Otherwise, I'm paying for it.
That's right. And I think people don't understand that idea of, through employer-sponsored insurance, who is actually footing the bill. You think, well, I have insurance through my employer, so they should pay for all of my health care. Well, let's think about employers today that provide health care for their employees. More and more companies are moving towards a self-insured model. I can tell you a lot of doctors don't even understand what that means. But just to remind everyone, self-insured means that company is assuming healthcare costs that they're going to cover. They literally are footing the bill for whatever they decide they're going to cover. Traditional insurance, which was a lot more common 2 decades ago, is when the company would pay the insurance company a fixed amount to cover healthcare needs for their employee population, right? So that's why it's changed, particularly over the past several decades, because companies are becoming more and more aware of what kind of healthcare services their employees are getting, because they're the ones footing that bill. So I think that's how the concept of insurance was traditionally and how it's changed over the years and what it means today.
Yeah. So, tell me if this is right. Did Kaiser kind of pioneer this? Or I guess there are a couple of big companies that kind of pioneered this, and then Kaiser took it and made it applicable to more people in a way, right?
In a way. I mean, companies, forget about Kaiser as a healthcare provider. Let's talk about major companies like Walmart and all these big employers. They're the ones who I would say really are at the forefront of understanding how much they spend on healthcare, which is why they're making all of these healthcare related investments. The Kaisers of the world are unique because they're healthcare systems that have assumed full risk for their population, which means in a lot of arrangements, Kaiser potentially can get paid a fixed amount to take care of a specific population and assume all of responsibility for that patient's healthcare. Whether they go to the hospital 0 times or they go to the hospital 100 times, they're responsible for managing all of their chronic diseases, their acute needs, and whatnot. So that's why Kaiser gets this. Kaiser really is at the forefront of that sort of model. And I'm trying to avoid using technical terms here because I want to level set. I really do think a lot of doctors who work in healthcare, who breathe healthcare, who do this every single day are just not aware of all of these different trends in how folks pay for healthcare and how that can potentially affect the type of care patients are getting, which patients they're seeing, and how they get paid.
I mean, why should these doctors care though? I mean, if my mom was a radiologist, so she would show up, read x-rays, go home, get paid a fat salary. You know what I'm saying?
Yeah.
I only care how much I'm getting paid. Why do I care about where the money's coming from?
Yeah, well, listen, it matters. It matters because in 2025, where doctors get paid from looks very different than how it did 20 years ago, or I bet how it did when your dad was getting paid. And the reason for that is a lot of people used to pay cash for their healthcare before. I talked about how that's changed. The other thing is, if you look at the Medicare system, it has fundamentally changed over the years. Medicare, I alluded to this earlier, it really sets the standard for how physicians get paid. There is a fee schedule out there that determines basically the sum of several components. It's clinician work, practice expenses, and professional liability insurance, and creates a score that's an RVU score, okay, relative value unit. And that sets the standard for what a physician's time is worth for specific services. Okay, and Medicare sets rates according to that score, there's a conversion factor that takes into account where you practice, how sick your patients are, other things, and then that will become a dollar amount. But Medicare sets the standard. And I talked about how sometimes Medicare can actually underpay for certain services. So then what happens? Where's the rest of the money coming from? Well, Medicare creates their fee schedule and there is no negotiation. We don't get to say to the federal government, I don't accept your rate. Their rate is the rate. There are a group of physicians who sit on the RUC, which is basically a committee that helps determine how many RVUs each service is worth, right? So there's some input, but like what's decided is decided. There's no argument. Where the leverage comes into play is when we think about contracting with specific insurance companies to be in their network or contracting with specific employers to be in their network. That's where the leverage comes. And the reason that's important is because if you think about negotiations, it's really hard to set a favorable rate when you're a solo practice provider out in, a city and you're competing against a large integrated health system, because that health system is going to be in a better position to negotiate with the insurance company. That is a big reason we're seeing private practices get bought out over time. This is one reason. Another reason is the fact, right, I didn't talk about the fact that Medicare payments have actually decreased over time, particularly as it relates to inflation. Physician reimbursements through the Medicare fee schedule have gone down and salaries for everyone else in healthcare has gone up. We have not taken into account inflation, overhead, increased administrative burden. All of those things are the reason that physicians can no longer afford to keep their practices open. And so, what happens? You go and you work for a large healthcare system because you went to school for 8 years, you did 5 years of training, you have $200,000 in debt. You do not have the time, you do not have the energy. No one taught you the business side of healthcare, what it takes to keep your doors open. And so this is the trend we've seen today, is that the majority of physicians are now employed. Employed by who? Anish, do you know who the largest employer of physicians is in the United States?
I'm going to take a guess. I don't know, but I'm going to go with Carlyle or BlackRock.
No, come on. It's even worse than that.
Okay, tell me.
United Healthcare.
How? Really?
United Healthcare is the largest employer of physicians in the United States.
Oh, how's that possible?
Because they have figured out this model of vertical integration better than anyone else. Okay? United Healthcare, which used to be just an insurance company, is now a provider group, provides physician services all over the country. They are buying out practices. They now are a large PBM, pharmacy benefits manager group. Okay, they are figuring out the fact that it is so much more profitable for them to integrate, keep all of their services under the United umbrella, create a monopoly over the healthcare system, but people are catching on.
Right. So okay, that's actually really interesting. Let's go back to what you were talking about with Kaiser and self-insurance in a way. So somebody explained to me value-based care one time, and it sounded a lot like how you described self-insurance, where kind of a hospital system gets paid an amount to take care of a patient population overall, regardless of what the conditions might be. Okay, this is your population, you're responsible for them, and this is how much you get, deal with the rest. Is that accurate?
Yeah, well, value-based care has many arms. What you're describing is one aspect of value-based care, like a capitated payment model, where there are a few flavors here. And I would say that when somebody gets paid a fixed amount to cover everything, that's the most extreme arm of value-based care. There are pieces that we've seen picked up to varying degrees that are some sort of like a happy medium between traditional fee-for-service, which is what I described earlier. Physicians bill for a specific service, they get paid a fixed amount for that service, and value-based care. And so, but you're right, the principle remains the same. Value-based care essentially gives you a fixed amount for taking care of a specific, let's call it episode. It could be, again, it could be more longitudinal, it could be a specific episode of care.
But an episode means what?
Let's say that I'm a surgeon, so I'm going to use a surgery example, okay? Let's say that I do a radical prostatectomy. The episode of care for that radical prostatectomy, I can define as the day the patient sees me for the consult, all of the preoperative services that I need to provide for the patient to get them ready for the operating room, the day of the surgery, the hospital stay, the overnight hospital stay, and the next 30 days. So it's about, let's say that's about a 90-day episode, right? But that was all the care for that specific condition for robotic prostatectomy. I'm using this analogy again because I'm a surgeon, but we have applied value-based care payment models to different surgeries through this episode of care sort of lens. Again, value-based care is different flavors. We talked about capitated payment models. There are other flavors of value-based care where physicians just get paid the normal amount, but there is some tie to quality. So what that means is they report their performance. Are they doing a good job? Are they doing a bad job? And they either get rewarded for doing a good job, which means they get a bonus payment of some sort, or they get penalized for doing a bad job.
And they is the physician, or they is the hospital, or they is the healthcare system?
All of the above. All of the above. It depends on the context, right? If I'm a solo practitioner, then I'm going to be taking that hit. And remember, this is yet another reason I alluded to the fact that solo practitioners are a dying breed because they can't afford to be the ones held accountable for this. So, the health system, they take a hit on a specific quality measure may affect them less than a solo practitioner out in Iowa.
So to my kind of untrained eye, what Kaiser was doing was a form of this, right? They're charging their own population a fee, and then they're taking care of that population for that fee and maybe plus a little bit more depending on how it all shakes out, right?
Yeah, and the federal government does this too. There's these things called accountable care organizations, ACOs, that exist all over the country that do the same thing that Kaiser's doing. I'll tell you a bit about what I do. Again, I'm a surgeon half the time on Mondays, Thursdays, and every other Friday. And then, the rest of my week, I'm director for specialty value-based care at Vanderbilt. We do the same thing. We've created these packages that self-insured employers can buy for a fixed price, a single fixed price. We cover all of the healthcare services related to that specific episode of care if the patient comes to Vanderbilt. And that means I take risk. That means if the patient's care costs more than the price that the employer is paying me, then I eat that downside risk. But if I do a good job, I get to keep the change.
Right. Okay. So wait, let me just understand this though. Vanderbilt is a hospital or a health system?
Vanderbilt is a health system. Okay. And what we have is this program called My Health Bundles. And we've created essentially 11 products that revolve around a single episode of care. And we have bundled all of the services that a patient may need from the day they come to the doctor's office for their first initial consult to the day. There's a few different episodes here, but I'm going to, again, refer to surgery because I think it conceptually makes more sense than some of the other non-surgical models. But we cover the initial consult, everything a patient may need before surgery. We cover the surgery itself, and we even put a warranty on the surgery. Some of the surgeries we cover for up to a year after. We take all accountability. If the patient needs to have a reoperation, if the patient gets a complication, we take responsibility for that. But that means that we hold ourselves to a high standard. We're taking a risk on ourselves. We're betting on our high quality. And so everyone wins. The employer is paying less for healthcare services for their employees.
Yeah.
We waive all copays for the patient, so they pay nothing out of pocket.
So these are employers who are self-insured generally?
Yeah, in the Nashville area.
Okay, and they're saying, all right, look, we're self-insured, so here's the deal. We're gonna send you these patients. Now, just out of curiosity, what if, making it up, I work for one of these companies that is self-insured and is contracted with Vanderbilt, but like I said, I'm an employee of this company, and now I want to go somewhere else for my care. Now
you can go somewhere else. It's your choice. It's a voluntary program. The employer only pays us for the patient who enrolls in our bundle, right? So, so they can contract with us. they also have insurance for everything else. We only cover 11 episodes, right? So if a patient gets sick for another reason, they still need their own form of insurance and they have their own covered network. We don't go through insurance. We cut insurance out of it, which is how we're able to simplify this, right? This is our iteration of specialty value-based care here at Vanderbilt by cutting out the middlemen and working directly with the employers who want to keep their population healthy. We're able to create this innovative program, and it's a big win-win-win.
Yeah, I mean, I would say it slightly differently, but you guys are the insurers, basically, because you're taking the risk. You're taking the statistical risk on the outcome.
Yes, legally, we can't be an insurance company.
Okay,
but yes, in concept, I hear you.
Okay, I got you. So you're not actually the insurer, but what's the rule around that? Why can't Vanderbilt legally be an insurer?
We're not built as an insurance company. We haven't had those legal contracts. We don't bill ourselves that way. We're a nonprofit provider organization, so we just got to make sure we're following the rules.
So, I mean, this to me as like as a layperson, as a businessman, I'm like, oh, that makes sense. There's an organization in the middle that has specialized knowledge about how this service is delivered and can figure out a way to deliver it to a high quality and a better price and get paid for that, basically.
Yeah, and that's value-based care. Keeping costs low, keeping quality high, and removing fee-for-service from the equation. It's really incentivizing high quality, low cost by giving everyone skin in the game. I'm framing it a different way to help people understand that, they hear value-based care and they cringe. They think, this is not, I want to get paid for the work I do, and this is too complex. But it's not that complex.
Right. So, So you're just not getting what you said, the quote unquote fee for service. But you are in a way. It's just it's a more holistic service is another way to look at it. Meaning paid for the entire service, not just the little sliver in bits.
Yes. And so remember I talked about how healthcare is so broken, so complex, so convoluted. Look at this, what we did. We simplified it. We're contracting directly with employers. It's one fixed price. Everyone loves it. We're able to waive copays because of the way we have this structured agreement. I'm bringing this up because I think I really want to see other physician teams, hospitals, health systems try to think outside of the box, outside of the constraints of this really convoluted healthcare system, and think about ways to simplify things. Because I think that's going to help improve how people feel about their healthcare, the experience of people who provide healthcare, the bills that patients get, the confusion, all of that. It's really interesting. Doctors talk about the fear behind value-based care, not just value-based care, but a lot of these new ways of getting paid. And they think that, as you said earlier, it's not the same. I make a lot less today than I made 10 years ago, 20 years ago, which is true. Salaries for doctors have gone down. I've talked about a few of the reasons why. There's many more reasons we haven't covered.
I thought they've been going up, at least the last few years.
Physician payments?
Physician salaries.
Are we including inflation? Are we factoring that in? Are we looking at... There's going to be a little bit of this, sure. But overall, physician salaries have steadily decreased if you look decade over decade over decade over decade. So, I think steadily we've been seeing a decrease for a variety of reasons in general. I'm making a general statement. This will be different when you look at specific specialties, specific trends, whatever. But just in general, physician salaries have trended downwards. But, I was saying we complain a lot about, I think, things that are not the root cause. And in my opinion, a lot of the root cause, in addition to misaligned incentives, is this complexity, confusion, all of that. I have an interesting example. I heard this story recently that Mark Cuban obviously owns Mark Cuban Companies, has a lot of employees under, that umbrella, and is a self-insured employer. He contracts directly with health systems, physician groups in his area to cover healthcare for his employees. And I heard that he actually negotiated a rate that is less than Medicare's rate, which is staggeringly low. I talked about the fact that in general, studies have shown that payments through insurance companies for physician services are often 150 to 200 to 250%. For some services, 300% of what Medicare charges, because that's how health systems recoup the lost money. If Medicare payments come under, they recoup it through these means. Tell me, How do you think Mark Cuban was able to negotiate a rate with a great health system under that of Medicare? How did he do that? He decided, just send me the bill and I'll pay for it. And the health system saves so much money not having to go through the claims process, bill insurance, wait for the payment. The payments come sometimes a year after. Figure out what patient has what copay, collect that copay. The patient didn't pay their copay. We need to loop in the collector. Forget all of this. The health systems are so happy to be able to provide Mark Cuban companies an invoice and get paid, I'm making it up, but 30 days after, then go through this convoluted system. What's keeping us from doing that?
Well, I'm sure I don't know the answer, but to run it back, that's an interesting point. So you're saying the purchasing power wasn't what did it. It was like, hey, look, you just send me the bill and we'll pay it on net 30. That removed enough uncertainty and time from the process for it to be worth it for them to pay a much lower rate.
Exactly.
Because if they're like, well, I mean, we bill for all of these, but we only get paid on half of them. If you're telling me you're going to pay it, I can actually charge you a lot less. I guess is value-based, like what you guys have talked about, or what you guys are doing at Vanderbilt, are you guys the only ones doing it? I forgot to ask though, the physicians who are involved, are they basically none the wiser that this is how it works? Or is their pay different, or how does this work?
Yeah, great question. So the key to our program in my opinion, that makes our program different is that we're physician-led. And so physicians are the ones who design these products to include everything that they would want to provide their patient. And the reason that's important is because, again, patient experience is important, but so is the clinician experience. Like, part of the pain in healthcare is that we have to sit there and argue with an insurance company and do what's called a prior authorization, justify why we're ordering a specific test. We took all those pain points out of it. We said to our physicians, tell us everything you would need. We'll make sure it gets covered. Because of that, there's less frustration, and they are very interested in the program's success and how is that measured. I talked about it being value-based care, so there's a tie to quality. So they are very interested in keeping our high-quality care going and keeping costs down. The financial piece, I talked about how, the nice thing about value-based care is the provider group, the health system, whoever's, providing the care does get to keep the difference. There is an incentive, there's a financial incentive. I can't get into the details of exactly what that means, but there's a piece in that in some way, either the department or, the chair gets to decide how those funds are used. That is an important piece though, because again, we are all humans and we need to be incentivized by something. Money may be it, high quality care may be it, removing barriers to practicing, good medicine may be it. I think physician-led programs, engaging physicians, making sure physicians understand that their voice has been lost historically in a lot of this, and bringing their voice to the forefront in these new payment models is critical for its success.
So that's interesting. And now I'm really glad this podcast is remote, because I'm going to ask you a question which might make you want to punch me, but I'm going to ask you anyway.
Oh, God.
Because now what you just said makes a lot of sense, right? Okay, great. Sounds to me like more people should do, more health systems should do that. Like, what's the problem? And probably more docs would like to do it. Let's just say, like you said, less frustration, more time spent doing the high value stuff, less time spent doing the low value stuff. I don't know the specifics, but even if they did get paid less, that would be better. I mean, if I'm a doc and I'm doing that, I'd be like, well, you can pay me a little less and take away the low value stuff. I'm happy to do that. I generally want to do higher value stuff, and that'll probably lead to me getting either paid more or having a better life or whatever in the long run. So I'm good. But it sounds like United is kind of doing the same thing. They're vertically integrating all of this, which, like, what's the problem with that?
Yeah. Well, don't worry. I don't want to punch you. I've heard it. I've heard it enough. Well, listen, I think going back to incentives, okay, if we think about incentives, United Healthcare, what is their incentive? What is their driver? The reason that they're absorbing physician practices is so that they can keep those healthcare dollars internal to their company. There is a specific amount of money that's going to be circulated in the economy, right? And so the purpose of United Healthcare buying physician practices is not to incentivize high value care. It's to keep the money in their pot. Does that make sense?
Sure. What makes you say that?
I mean, they have shareholder calls. That's who they're beholden to. It's just a different, if you look at the organizational goal, it's a different goal when you're accountable to your investors. You know that better than I do.
I don't agree with that. I think that's saying that companies that are for profit have like less pure motives than nonprofits, which I just don't believe.
No. I don't mean they have less pure motives. I just think, who are you accountable to? Are you not accountable to your shareholders?
You are, and you're delivering them a return. But let me be clear. I don't have any allegiance to United Healthcare. I'm not really defending them. I'm just, playing the other side of this. But look, I think the best companies on the planet have a mission and a purpose that they're trying to accomplish. And their economic activity is the result of trying to accomplish that mission. And the investors that they have recognize that all returns are subject to that mission, like to the purpose of that entity, mainly because that's good business and because you can't be all things to all people. So that's the best businesses operate that way, and really good ones. Now, I'm not saying that's what United is doing. I don't know. I haven't read their annual reports or anything like that. But I'm trying to say that being accountable to shareholders is not enough of a reason to say that they're not doing something that's productive and like really high quality.
I hear that. I think part of my fundamental belief, and I alluded to this earlier, is that physicians have let go a lot of their power and a lot of their voice, hiding behind the excuse that, well, I just want to practice medicine and I'm not an administrator. And I'm sure you have heard that in a family of doctors.
Oh, yeah. Right. No, I mean, totally. Go ahead.
And I was just going to say, I think the reason that United Healthcare, being a large employer of physicians, the dying breed of independent practices, I think that all illustrates the problem of physicians letting go of control of how they got paid, perhaps losing sight on the importance of advocacy for how they get paid. And I think that physician voice has gotten lost. And so as we lose our autonomy and we become employed, we become parts of these integrated systems, we lose our leverage to practice medicine the way we want, right? And that's when all of these gripes you hear come into play about like, God, I spend my day clicking on the electronic medical record instead of actually sitting with my patients. Or, there's been a lot of evidence out there that suggests that, I'm going to say this lightly, knowing your background, knowing where you've been, where you come from your prior work experiences, there's a lot of evidence out there that suggests that when practices get integrated or bought out by private equity, the quality of care potentially goes down because of cost-cutting measures. And so what's the best way to, improve productivity? It's to jam-pack your schedule with, 60 patient visits, so you're spending less time with each patient. Like, a lot of that is happening because of the administrative burdens that have landed upon us because doctors have lost their voice. And so, I say that to underscore the fact that as we become more and more integrated, as the Uniteds of the world absorb physician practices and pharmacy benefit managers and buy out pharmacies and start buying out health systems, and we lose our leverage. We are beholden to the giant that is Optum and United. And that's kind of the issue I have.
Did doctors ever actually, I heard you said about losing control, but did they ever actually have it? I mean, is it maybe that I'm going to just look at from like the 60s until call it the 2010s when all this really was happening. There's another perspective, which is that physicians were generally the beneficiary of being a very highly paid service provider, like a uniquely highly paid service provider, which, what do I want to say? It's almost like being a professional athlete or something like that. And you get to be a professional athlete in the NFL or the Major League Baseball or whatever because somebody created a forum that rewards this skill of hitting a baseball or throwing a football, somebody created a forum where if you can learn anatomy and then read an x-ray, between the 70s and the 2000s, you could get paid a good amount of money to read that.
You did get paid a good amount of money to read that. You're right. You did. And you got complacent. And so when the world started changing around you and it started requiring $250,000 of debt to get that degree, or it started requiring $1 million in capital to open that brick and mortar office. It is not, I mean, I hear you on what things used to be, but it is not like that today.
Well, and agreed. But my point is that the people that were the beneficiaries of it for the last, call it 50 years, had almost no hand in creating it. They were just beneficiaries. They just got somewhat fortunate by circumstance of birth and education and time. You know what I'm saying? So I'm not disagreeing that it's changed. I hear you. Like, private equity has bought a lot of these. You can't really operate on your own as much as you used to. That's been increasingly harder. But what I'm poking at is when you call it like the physician autonomy, I'm kind of like, what right
did it
do you
ever
have
exist?
to this? I mean, like, did it exist? And what right do you have to hold on to? What are you talking about? Where did this autonomy live?
I mean, lawyers have this autonomy. They get to determine their rates, and you're beholden to what their rates are, and you sign the contract. And like, let's not pretend like physicians are the only ones who have that privilege. Of course, I hear you on that. We're certainly more fortunate than most. But when I sit there and respond to my patients or pick up the phone and make a call to review pathology results, those aren't billable hours. Like, I don't get to round up the 10 minutes that I spend. I don't get to say, oh, we round up, we bill by the hour, that's $450. Just a different perspective there.
Yeah, isn't it different though, a little bit? Like, because it's funny, the part of my brain that, I'm pretty diehard capitalist, but then the part of my brain that releases capitalism was when I start thinking about doctors.
It's because you come from a family of doctors. You hear the gripes and you're like, oh, guys, shut up.
My decision not to become a doctor was like, well, I don't think I really want to, first of all, I don't want to do that. I don't want to go, a lot of what I heard growing up even around, so not just my family, like so many other doctors and people going to med school, I grew up around it. And this is culturally, it's not everybody, but a lot of it was about like how much money you could make and which profession pays the most. I'm like, look, everybody's entitled to make whatever money they want. I don't care. But if it was me and I wanted to become a doctor, it would be about the patient. Like, that would be my reason for becoming a doctor. It'd either be about the subject matter or about the patient. That would be my personal reason.
Yeah, and I do think, Anish, that is why the majority of us went into healthcare. We don't survive. Like, I will tell you, I did a surgical residency. The motivation of making money was not going to help me survive a surgical residency.
Yeah.
I mean, it was brutal. Like, 80 hours were the easy weeks, You just can't survive that if money is your motivation. And my story's the flip side in that I come from a family of doctors, but my mom begged me not to go into medicine because she told me, I mean, again, generationally, it was probably a few decades after your parents. So she had missed that, I'd say the golden age. And she told me, based on our family circumstances and what she had to go through when she was training and I was an infant, she told me, are you crazy? Why would you want to do this? There's a much better, you should go to law school. Like, God, she used to tell me, you love to argue, go to law school. You'd make a great lawyer. Like, don't go to med school. There's much better ways to maintain a good quality of life and have a secure future. In other words, it's not worth the money. And I think most physicians you talk to today will tell you it is not worth the money. It is not worth the debt to income ratio. It is not worth the years of training and sacrifice and giving up your 20s and your 30s. And so you really, those of us who are doing it, the majority of us, not everyone, but the majority of us do it because we love it and because we put the patient at the center of our priority list.
And I think that, look, I can tell that about you, but I think that, personal opinion anyway, I do think that's the difference. Like, look, lawyers have to take an oath to do right by their client and not disclose certain information. Doctors have to take an oath to take care of the patient. I do think that matters. I mean, I love what attorneys can do for me because they can guide me and counsel me in a way that, because I'm paying for it, that nobody else can guide me and counsel me as a business person because they're sworn to protect me as their client, sworn to do that. And they have to. Everybody else has their own agenda that they're trying to wield in the conversation, but I know that. So no matter who I ask for advice, anyway, that's what I think is beautiful about the legal profession. Now, you're right. They do get to charge the rate because it's like, they're like business doctors. That's what they sort of are. But they don't, a lot of times as attorneys, participate, even the crazy rates that they charge, they really don't participate in the upside of the value that they're creating unless they invest or something like that. So it may look greener, but I don't think it's that much greener.
Well, I think this brings it full circle though, right? And so that's my point is I'm a big believer in fixing a lot of the gripe we have with healthcare and not fixing the entire thing, but a lot of the problems will be improved by changing how we pay for healthcare. And so you and I are aligned in that we need to realign incentives. So currently, for the majority of doctors, the incentive is not emphasized in terms of quality. The incentive is productivity, because the majority of doctors are still getting paid fee for service, right? And even if you're, I alluded to this, bought out by a private equity firm or integrated into a larger physician group or absorbed by a healthcare system, the emphasis is on volume and the number of patients you're seeing, the number of surgeries you're doing. I believe that if we keep the patient at the center of the model and incentivize people to keep their quality as high as possible, inherently costs will go down. And I believe that most doctors, call me naive, but I believe that most doctors are in it for the right reasons and they're in it for care of the patient. And so I'm bullish on value-based care. I think it's the future. I think it has the potential to fix a lot of what we're talking about. I recognize that it's a complex past. We've scratched the surface today. I mean, there's so much more here. And I just want more doctors to understand that there's opportunity for them to take a more active role in shaping how the future of healthcare looks. I think that gets lost a lot because I think, you sit in the surgeon's lounge or the doctor's lounge and you listen to all the complaining or you read the headlines and you're like, oh my God, Amazon Health, One Medical, Dollar General Mobile Clinic, CVS Clinic. Like, I'm powerless in this system of giants and behemoths that are changing my field. And if you back up and you recognize that there's opportunities to cut out some of this middleman, take ownership like we're doing. We're working directly with small and medium-sized employers here in town and realigning some of these incentives. Think outside of the box. There's a lot of opportunity to kind of shape the future.
Well, I think next time we should get into one of those, whether it's like One Medical or Amazon Health. Let's dive into either a recent event or something that's going on. We can pull it apart and see what it means for everybody. Because like you said, we just scratched the surface, and I certainly don't have a great solution. My only solution is to buy everybody a Peloton so they can just exercise more. That's all I got.
Yeah, that's a start. I'm glad you said buy everyone a Peloton and not put GLP-1s in the water. So that's a really good start.
I guess that could work too. I hadn't thought of that one. Well, everyone, this has been Backtable Industry. I'm Anish. This is Dr. Ruchi Talwar. You can find our episodes on Apple, Spotify, YouTube, and on backtable.com.
Thanks so much, Anish.
Thank you.